Yeah, we're live, Nigel.
Okay. Good morning, everybody, and welcome to the governing body meeting in public. Thank you very much for joining us on a March morning. I hope this finds everybody well, both virtually here and wider if you are watching this. We've got some apologies today from Simon Bell, and Simon is unable to join us because of annual leave. However, we do know that the finance report will be picked up by Phil Metham in his opening remarks and his piece, and then we won't formally have a verbal report on the finance position. But if there's anything that any members want to pick up as we go through, please let me know. Declarations of interest are as stated, and if there's anything further that people want to bring to my attention as we go through the meeting, please do so. I know that now that we're going into a different part of the next steps through the white paper and integrated care systems, there are a few of us on this call now that have some dual roles now. So myself, I'm the clinical lead of Humber Coast and Vale Integrated Care System at present, and that will happen for this year coming as well. Michelle, do you want to explain your role in Humber Coast and Vale? And then I think, Ruth, you've got a role that you might want to explain as well, or just state for the record.
Morning, everyone. So yes, I've taken up an interim position of 2 days a week as Director of Quality and Nursing for Humber Coast and Vale, in addition to my Vale of York Chief Nurse role.
Thank you. And Ruth?
Yeah, I've taken a position. It's currently just half a day a week with Humber Coast and Vale Mental Health Collaborative, and I'm the GP clinical lead.
Great, thank you. Okay, I don't know whether there's any further declarations, but if there are, please put your hands up. And Chris, was there something for you?
It's probably just worth mentioning I'm on the Humber Coast and Vale Strategic Digital Board.
Great, thank you. Okay, brilliant. Thanks very much for that. So I'm just having a look at my agenda. I'm flicking screens to make sure that we've done those first two bits. That's fine. And then it's my pleasure that we've been able to bring a patient story to this session today. And it's great that Charlotte Hoban from St Leonard's Hospice and Jenny Brandon are here to help talk to us about a patient story. Can I ask Michelle, do you want to introduce a bit, and then we'll pass over to our guests?
Thanks, everyone. So yeah, really pleased that you could both join us this morning. And we were keen on discussion with Nigel to get back into sharing patient stories at the beginning of governing body, to keep it real and remind us all what we're here to do. And we started again at a Quality and Patient Experience Committee last time we met with this story, and it was so impactful. And we just wanted everybody to be able to hear it. And we didn't want Charlotte to do anything different than she did last time, because as I say, I think it's going to have such impact for you. And I think we've had subsequent conversations, haven't we, about what else could this platform do for homeless people, particularly around COVID vaccination, knowing that Charlotte's got relationships with this cohort of individuals. So it's already led to further really good conversations. So without further ado, I'll pass you over to Charlotte, and just be yourself. You are amongst friends, and just tell us about the amazing work that you do. That'd be great.
Oh, thank you so much. What a lovely introduction, and thank you to Jenny for coming along to support me today. It's great to come back. So is my screen shared? Me and technology. Can everybody see yeah, excellent. Okay, yeah. So we'll get started. So yeah, as has been said, I'm Charlotte Hoban, and I'm doing a homeless palliative care project that started last year in November. My title is of Complex Care Coordinator. So I just want to really talk to you a bit about why I'm doing what I'm doing, and then I'll tell you a patient story about Karen, who I'm supporting, name change for confidentiality. Oh, There we go. So what is homelessness? So it isn't just rough sleeping. You know, it's people that are in insecure accommodation, people that are likely to be kicked out, people surfing. So actually the homelessness numbers don't always represent the hidden homeless. And also, of course, refugees and asylum seekers are at massive risk of homelessness. So there she is, Dame Cicely Saunders, the patron saint of the modern hospice movement. And what she said when she started the hospice movement was that everybody matters, and it's about helping people to live peacefully and to live until you die. And that's a really important part of what I'm trying to do with the complex care coordination is, you know, getting everybody in, you know, everyone should have access to palliative care, and it shouldn't matter what your situation is, and we need to try and break down those barriers. So it's about living well, and I think by changing the focus from dying to living with advanced ill health, that's really what has helped me to engage with this client group. And it's also about, you know, treating the whole person holistically and their loved ones. Unfortunately, we have had a lot of deaths within the homeless community and drug and alcohol services in York in the past few weeks for a variety of different reasons. And I think that just highlights the importance of this project and hopefully, you know, the project's ongoing funding. So just some shocking statistics there, that the life expectancy of someone experiencing homelessness is 44 for men and 42 for women. You know, that is 30 years or more than the general population. And, you know, this is the reality of it. And this is why we need to be looking at palliative care and opening it up to everybody, because otherwise we're going to miss these people. And the crisis report from 2012, which maybe seems a bit outdated, but actually, sadly, is still really relevant, that the deaths are often sudden and lack dignity and with no access to palliative care. And I can certainly say, you know, the past, you know, couple of weeks, we've had about 3 deaths, all of which have been sudden and with no access to palliative care for a number of different reasons. So we talk about trimorbidity when we're thinking about the homeless population. So trimorbidity in terms of mental health problems, physical health problems, and substance misuse. And they've got high rates of morbidity with significantly lower life expectancy. That was the Homeless Link article that was published in 2010. So I'm not going to talk about all the different things that they suffer from, but just so that you've got a bit of a background of the client group that I'm working with. You know, 80% of the homeless population have at least one physical health problem, and that's just physical health problems. You know, the majority have mental health problems and substance misuse issues also. So we know that there's inequalities in accessing palliative care, which is why the funding was granted for this, and St Leonard's Hospice and Changing Lives York have put funds in order to create this role, because it is well recognised. The CQC published a document in 2016 that said that access to hospice and other forms of palliative care are currently inequitable, and that is still the case, although there's definitely more awareness around it and people are making more noise about it. And so hopefully we're getting towards a place where things are going to start changing. We're not just talking about it anymore, action is being taken. And, you know, the homeless population have multiple disadvantage and are less likely to receive care at end of life. And we don't always understand or fully consider the specific end of life needs for marginalised groups. So a new approach is needed. Everything I do is based on the advice of Schulman and Hudson, who produce key recommendations. And it's, as I've said before, shifting the focus from dying to living with advanced ill health in order to have repeat conversations with them, engage with them. And this will become more clear when I talk about Karen. So it's a trauma-focused care, because everyone that I've met has really horrendous trauma histories, and no one service can do it all. We need to all work together. So I'm going to talk about Karen now. So Karen is 37 years old, female. She was one of the first people that was ever referred to me by York Drug and Alcohol Services. So a little bit about Karen. She's been around the resettlement system numerous times. She's never had a tenancy of her own. She was street homeless this time last year, and she'd been street homeless for about 18 months, I think, by this time last year. She has 2 children that she doesn't have care of, but she does have, she does see them because her mum has custody of them. She's got a personality disorder, IV drug user, alcohol dependent, and she has end-stage alcoholic liver disease, which is what I've been trying to support her with. So I met her when she was in hospital. She had 20, was it 20? I could be making that up. I think actually no, 17 A&E admissions last year alone. This year she's had none, but I'll come on to a bit about that later. So I met her with the rough sleeping navigators who were trying to get her housed, and we started making a relationship from there. I kind of thought, oh great, make these relationships, get advanced care plans in place, jobs good and kind of thing. I was very, very wrong about that. We don't have an advanced care plan in place, but yet, the other work that we're doing together is really positive in terms of pre-bereavement support for the children and supporting her mum to support the children. Her mum's big fear is, how it's going to affect the children in the long run, because Karen has gone from the children's lives on a number of occasions for long periods of time and has always come back. So it's identifying that and working with a mum and with the children to try and reduce the trauma, because we know that early life trauma contributes significantly to people experiencing mental health problems, addictions and homelessness. So it's trying to break the cycle. I work in an assertive outreach model. I go to them. I spend time going out with the rough sleeping navigators, which has been really helpful in terms of engaging with these clients. And also I'm trying to focus on early referrals. So we've started this work with Karen because we want to try and know what she wants at the end of life. And although I've not managed to do an advanced care plan with her, it's taken me since November to kind of have a relationship with her where she can trust me. You can see from the slide that she's got a history of disengagement with services. So it was really important that I did something a bit different to other services, and the rough sleep navigators are assertive outreach, and that model seems to work really well. So I went with that, and she doesn't trust people easily. She's got a complex trauma history, and I really had to prove myself and that I was working for her and not for my own agenda, and keeping her in the centre of everything as well as supporting the ones that she loves. I've been working with the hepatology team at York Hospital in order to try and get a clear shared pathway between the hepatologist, the hospice and the drug and alcohol team to increase referrals into palliative care. We know that liver disease anyway, people with liver disease don't have the same access to palliative care as people with cancer would do. So there's an inequity there, which is all part and parcel of this, what we're doing and trying to get more people in, as I keep saying. So I'm just going to go on to the next slide. So this is a bit of feedback that I had from Karen and from Karen's mum and from the hepatology specialist nurse. I'm not gonna read it out. I just wanted to highlight that even though I've not really been working with her for that long, I think I got this feedback in January, so that was 2 months after working with her. Unfortunately, Karen has had another relapse, so I'm in the process of trying to engage with her again, and we're trying to get her to a place where she's gonna find a tenancy of her own, and we're going to look again at the advanced care planning, because although she's not relapsed since November, unfortunately she has relapsed again, and we haven't been able to get in touch with her. So part of my role is also going out there and finding her and seeing how best we can support her, because my role isn't about demanding abstinence or demanding anything from anyone. It's about supporting her and her wishes and what she wants, and she has capacity, and it's her choice if she wants to continue drinking. So I'm there to try and get the best outcomes for her, but by not dictating what she should or shouldn't do, and with no judgment. Like that's a real big thing. This client group do feel very judged and have a tendency not to be honest if they think that you are judging them. So just having that real open and honest relationship has really worked really well in terms of supporting Karen and Karen's mum as well. So I just want to leave everybody with this, and it's that everybody, no matter who they are, deserves the best quality care at the end of life, and it's our shared responsibility to tackle inequalities. So I thank you for allowing me to come and speak again, because, you know, talking about this and getting the conversation started is partway towards, you know, reducing the inequity that these people face, and, you know, getting them living well at the end of life with supported and dignified deaths with their wishes and preferences in the centre of that care, and the care that reflects the views and motivations and needs of the person. And more importantly, never giving up and ensuring that the voice of the homeless population is heard in order to tackle the inequalities. So I like to think of it as a hospice without walls, going out into the community and reaching the disadvantaged groups in our society and opening up hospice care to ensure that nobody's left behind. So thank you very much for allowing me to talk today. And it's been a pleasure to see everybody.
That's brilliant. Thank you very much, Charlotte. Jenny, is there anything that you wanted to add in at this point before we open it up to colleagues for comment or questions?
No, just thank you again to Michelle and the opportunity of allowing us to tell our story. St Leonard's initiated funding for this post, but it's really important that this comes across as a true partnership with Changing Lives and our wider system partners. We've got funding for this post until the 1st of November this year, but I think everybody's in broad agreement that this should continue and grow. I think from our perspective at the hospice, it's a validated opportunity to extend our offer out into the community, and therefore Charlotte provides that incredible brilliance and that additionality to our hospice at home, our hospice without walls, as she's just described. So no, I've nothing further to say other than she's a shining star. She's been brilliant at leading this service for us, and I'm immensely proud of all that she's achieved so far. So yeah, over to you guys for questions. Thank you for the opportunity.
Well, thank you. And I would just like to echo that and say thank you, Charlotte, for all your work for our citizens. It really is appreciated. And just reflecting on the effect of trauma in people's lives. And we've talked about it a lot in governing body and in various committees around the effect of early life or previous life traumas and what this brings out. Yeah, okay. Anybody like to come in? Julie, yeah.
Can I say thank you? It's lovely to meet you again, Joanne, and it hasn't lost any of its poignancy for me today. It's wonderful. And the person-centeredness of this really captures my heart. And what I really get is how difficult it is to engage with our homeless population, and gaining their trust is no mean feat. So huge respect for that. And thank you for the work that went on afterwards with everybody else that was involved after our deep dive. We're seeing a lovely pattern emerging from deep dives, and the work doesn't stop there, it goes on. So thank you for that, and I can't wait to watch this space.
Great. Helena, and then we'll go to Phil and David.
Yeah, I just wanted to echo what you said about the trauma-informed approach, and just highlight that that's what social prescribed and link workers often can do. So there's a real overlap between what Charlotte's describing and loads of lessons that we can tease out in the other work that we're doing with what we have called hard to reach in the past, and what we now realise are not hard to reach. It's that we need to work out how to reach them. So I think that trauma-informed approach should underpin most of the work that we do in particularly health inequalities, population health work, both within the city and around.
Great, thank you. Phil.
Thanks, Nigel. Charlotte, that was really cool. Really enjoyed that. Thank you. I love that phrase, hospice without walls. I was just thinking about that and where the NHS and social care in particular is going for the next decade. And if we asked our large statutory organisations and institutions, which are very much influenced by the walls and the buildings within which they operate, that it really does take you to a different way of thinking about the offer of health and care that we could shape for the future. So yeah, really great, thank you. And And to have a board meeting, Nigel, in which we have the phrase "jobs are good," that's a champagne moment for me. So yeah, cool. Thank you very much.
Brilliant, thank you. David, I think you wanted to come in, and then Chris.
Yeah, first of all, apologies for late joining. My internet just failed completely, but has popped back on now, thankfully. So here we are. Apologies for that. Yeah, thanks, Charlotte. Yeah, I read it very carefully before. And what I'm interested in is not just the end of life for homeless people. It's, you know, what happens before that, and it is one of my kind of pet favourites, really. And I do some work for another organisation, which is a GP federation in Rochdale, and they provide 3 times a week street level clinics at the soup kitchen, and GPs volunteer their time, nurses volunteer their time, and ordinary people like me volunteer their time to do the admin and so on. Is there anything like that in York? Because surely what happens before the end is really just as important.
Hi, David. That sounds amazing. I gave you a little round of applause. That's something that I'm really interested in. The street outreach health workers information had just been published, I think, a couple of weeks ago now, by the QNI, which was advocating for all those services, street outreach in particular. We've got in York, I mean, by no means am I the expert on everything that we've got, but from what I've come across, there is a substance misuse navigator, Mark, who is seconded from Changing Lives, who goes out and finds people to support them with their substance misuse issues. And that was a 12-month pilot. I think he started a similar time to me in November, and that's been really positive. York Medical Group are really great at going into the hostels. But as far as I'm aware, there isn't a kind of street outreach clinic like there is in other places like Edinburgh. Do a particularly good one with you know, multidisciplinary team that go out, and it seems to work really well in terms of health management. And absolutely, it does need looking at, not just the end of life stuff, because they don't have access to healthcare services full stop for a number of different reasons. So yeah, definitely it's something that does need to be addressed, and what you're doing in Rochdale sounds incredible. I'd love to know more about that.
Well, yeah, do contact me, but I mean, I don't want to take up time, Nigel, but I mean, sometimes you're just there at the clinic and people turn up from the street, and their injuries and the state of their legs and their arms with skin ulcers and so on is just you know, and not to mention the stench and whatever. But the nurses and the GPs just dive in and get on with it. It's fantastic. So I'll be very happy to give you any more details. Just contact me. Yeah.
Great, thank you. Chris, and then Ruth, and then Phil.
Yeah, thanks so much, Charlotte. That was amazing, really amazing to hear. And yeah, I was pretty choked up actually hearing about Karen a couple of times. And if anybody knows me, that's not a common thing. So I really appreciate the story. It's fantastic and pretty stark. You know, those numbers of 44 years old life expectancy for men, 42 for women is just shocking, really. And I feel pretty ashamed of the blind spot when I saw you coming to talk about homeless palliative care. I thought, my goodness, I've not even, you know, come across that or thought how that works. So yeah, I feel guilty about that, and I'd be really keen to work with you to understand some more and see what as GPs we can do and get you, you know, make sure you're well embedded with all of the palliative care leads in general practice, and make sure you got the support from primary care that you and these patients need. So yeah, reach out.
Great, thanks, Chris. Ruth?
Yeah, just again echoing what everyone else said about how brilliant this service sounds. But I wrote down one thing that you said that I think for as a clinician, I think is just so important. So I just wanted to say it again because I think it's so important. And it was about when you said you're getting the best outcomes for her without dictating what she should do. And I just think that's so important, and that no judgment, and that's something I think that I'm going to write that on my wall, because I think it's just such an important thing to say, because I think we are sometimes guilty of going down this medical model of telling people what they should be doing. But yeah, doesn't work. So yeah, thank you.
And Phil.
Thanks, Nigel. Thanks, Charlotte. That was really impactful because it made it real for all of us, particularly when you focused on your case study with Karen. Can I just explore very quickly one of the themes that's been recurrent so far, which is about the issue of trust and how that leads to a level of engagement with public services. We focus so far very much on health and care services, which will be in the front line in dealing with these people. But a significant interface that some homeless people will have with public services will be with the police and criminal justice system. Depending on the quality of that experience, that will affect very much their overall level of engagement, I guess, with wider public services. Have you got any input you can give us on that?
All I can kind of say about that is when I've been doing street outreach and spent some time, sat on the streets with these people, is that they generally have quite a good relationship. I know quite, that kind of the offending, a lot of them do have an offending history, but they are, not all as a general rule, but the people that I've met actually seem to have a good relationship, particularly with the police that are out and about on the streets. They seem to be really, really caring. And I think it is just human kindness goes a long way, and not trying to dictate to them what they should or shouldn't do. I mean, obviously there will be some hostility towards the police in terms of if they're, drug dealing and things like that. But, in terms of an assertive outreach model seems to be the most effective for most services. So maybe it could apply the same way.
Okay, Charlotte, I'm very grateful for that. Thank you.
Brilliant. Okay, well, if we've got no other comments, we'll just say again thank you to Charlotte and Jenny for coming. And I think Charlotte would probably, what this has shown is this start of a lot of conversations that you could have with us, and we could link in a lot with you as well. And we're doing lots of bits of change at different levels around the system. And one of the things that we're working with is somebody who talks about linking the system to more of itself is one of the big ways that you can help facilitate change. And I hope this sort of doing something like this is linking the system to more of itself, because we're all in it together, but sometimes we just don't know we're there. So it's really great to see you here today. Thank you very much. We'll keep on getting in touch with you. You keep on getting in touch with us if there's things that you need, because that's what we need to do and build the relationships up from here. So I just want to say again, Charlotte, thank you very much for all your work, and Jenny, thanks for coming along as well.
Thank you, everybody. See you soon.
Thank you very much.
Okay, that's great. A great start, and thanks, Michelle, and Julie bringing that from QPEC for us. There's a couple of hands still up, but I think those are legacy hands, so I'll let you put those down if that's all right, or else I'll get confused. And we're just going to go back into the agenda. I'm just looking at another screen so I can see my agenda whilst hopefully looking at you as well. So that was item number 3. So item number 4 is looking at the minutes, which I hope you've been able to see and to approve. Please put your hand up if there's any problems. Matters arising, I've been through those. Those all seem to have a date against it, apart from maybe the last one, but maybe Michelle, you maybe pick that up later on, which I think was around nursing home liaison, so we can pick that one up if that's all right. And the other thing to say, which we hopefully the exec members can pick up as we go through, is that we have had a question from Bill McPate around the changes to North Yorkshire County Council Healthy Child Programme, and this is in relation to the board assurance framework. So what I'll do is I'll read it out, and then hopefully what we can do, and please hold me to this, is that we can make sure that we cover this as we go through the meeting for Bill. So Bill says, the Vale of York response to the above, which is the changes to the Healthy Child Programme, accurately envisages a deterioration in provision for children, particularly the reduction in surveillance for emerging health concerns. If these are not identified and addressed at an early stage, they will impact on NHS care at a later stage of a child's development, impacting on demand for services already stretched and avoidable damage to children. As the new model to be operated by NYCC is intended to be introduced in April 2022, it is rightly identified in the board assurance framework. That discussions are taking place at an executive level is noted, but will the board please indicate how it intends to manage oversight of this risk, given it is a service commissioned and delivered by a third party? So that's maybe just something for us to note at this stage, and then come back to as we go through that board of assurance framework, if that's okay. Okay, so if that's all right from that point of view, just doing a bit of jiggery pokery with the screen. I think I've said about the other things. Like I said, the item 10, which is the financial performance report, this was discussed in detail at both the financial performance committee and the audit committee, and the chairs of those committees are here. And also items 11, that's Christine Pearson will be coming to present this, and Michelle Carrington will introduce those bits. So if that's all right from that point of view, bit of housekeeping there, we'll just move straight on. And Phil, this is over to you, if that's okay.
Thank you, Nigel. Hi, everybody. So I'll work through the report that's in your papers relatively briefly. 1, 2, 3, 4 areas to touch on. When we come to protected learning time, Nigel, I might invite you to or other colleagues to brief on that in a moment or two. So I'll start with the financial position, as Nigel suggested. So for 2021, the Vale of York CCG, as with other organisations in Humber Coast and Vale, ICS is facing a low risk end of year position that's under constant review by the finance committee, but we have a high and strong level of confidence about our end of year position. So our partner organisations within the NHS in North Yorkshire and York are at the moment equally confident about their end of year position. The one thing that I would just raise that isn't a 2021 issue, but could be for the early stages of 21-22 is the unknown policy position at this stage around how discharge from hospital will be funded and the arrangements for that across local government and the NHS. Indications at the moment are that the current policy position that runs to the 31st of March may not be extended. So as we go into the next financial year, that has the potential to create a new financial risk for this organisation. That's known to the Finance Committee and under review, and colleagues from both local government and the NHS are working together at the moment to develop options to mitigate that risk. There is nothing obvious and clear that we would do. There are big numbers involved. So Nigel, if we can just register and record that as a risk. Thank you. That positive financial position means we're able to do some good things. So you'll see in the notes that the number of dermatoscopes that we're able to make available for general practice is going to increase and double. So there are some positive aspects to this for patient care and for our professionals in the system as well. So broadly a positive position, Nigel and colleagues. Thank you. I'll move on to recovery. I'll start with the vaccine position. I won't go into the detail. Michelle and or Steph can do that later if colleagues would like them to. Just would want to again acknowledge and commend the extraordinary achievement of our practices in helping take forward the vaccination programme, supported by many of our own staff. I would like to commend to to the governing body of its members. Michelle and Steph have been tireless with their teams over recent weeks, and I really do mean tireless. It's been an extraordinary effort and continues to do so. I would like us to be able to record that if we could in the minutes, Michelle, and also if we could record and send our thanks to the RSS, who have been really helpful in the way that they've supported the call and recall of patients into the system for vaccination. It's not part of their core role, but without their contribution, we would not be where we are in terms of the progress that has been made. Perhaps we could write on behalf of the governing body. Nigel, discuss that later. Acute recovery, if I just mention that, continued focus on cancer services. We are on track for some aspects of that recovery, but we should not underestimate the size of the challenge ahead and the impact on both known and unknown patients. So it continues to be a focus and an area of concern. I just mentioned mental health as well. So within the city, the local MPs have asked for us to let them know what within the city organisations would propose to do about the increase in demand. There's going to be a meeting towards the end of this month that will be a direct response to that, and I would like to talk with Ruth and Helena about how we might do something similar for other parts of the Vale as well. We would of course have to do that with other NHS organisations that are involved in the wider North Yorkshire geography, but I think if we need to take a lead on that in that respect, then we can do that. We can do that too. Moving on to governance, as recorded in the report, Council of Reps have taken the step to approve the rollover of lay member contracts for 21-22, like governing body to note and agree with that. So we will continue to receive input in terms of good governance across our organisation and our statutory duties, but also involve Julie, David and Phil in how we take forward the transition, not only from a governance perspective, but how we support our staff during this transitional period, so that there's a sort of champion, a staff champion input to that, which the executives would really appreciate and value. I'll come to PLT at the end, Nigel, if I may. Last thing from me about local government reform. So you'll see in the papers that consultation has now started about local government reform. North Yorkshire County Council elections for this year have been deferred to May 22. Governing body colleagues will be familiar with the two options on the table. The ICS has continued to, and in writing, supported the North Yorkshire and York option. Nigel and I have previously consistently supported that as well, and we would propose to do the same as part of this consultation exercise with the support of this governing body. I'll pause there for comments and questions. Nigel, thank you, but if you'd like to pick up the PLT issue, you're better placed to describe that than I am. Thank you.
Yeah, thanks very much. Well, PLT will continue, and it's been shown to be one of a positive from the last few years, and we've had very good feedback from our member practices around it. We of course cancelled the January one because of the COVID response across the NHS. But we're hoping that the April PLT will go ahead, and this will be a place-based or locality-based PLT to allow PCNs to discuss their plans and what they've been doing over the last year, and going forward how they integrate into the new ways of working into 21-22 and 22 onwards. So that's from April, and then July we are hoping, if restrictions allow, that we will all get together as we did before at York Racecourse for a a sort of face-to-face learning event if that's allowable, given the restrictions and the easing. So that's where we're at with PLT. Does anybody want to pick up anything either on PLT or on Phil's report? Sharon.
Yes, thanks, Nigel. Just want to comment really on the local government reform and the place comments in Phil's report. I can speak on behalf of North Yorkshire County Council and City of York Council in thanking the CCG for the involvement that you've had in the consultation so far, and your support for the proposals. That's been very welcome. And then again, you know, City of York Council, that I can speak with any authority on, is very involved with colleagues in the CCG around the development of models for future planning and delivery of care at place level. I think it provides us with perhaps a once in a lifetime opportunity to be able to really focus on the needs of our citizens across the city, working across organisational boundaries to meet the needs of our population. And in the City of York, to try and address those deep-rooted health inequalities that often get overlooked. So I'd just like to thank the CCG for the joint working around that, and obviously that will continue to gain strength over the weeks and months ahead. So thank you for that.
Thanks, Sharon. And I think that's absolutely true, isn't it? That if it's something, what we've learned in the last year is about working together for our citizens and patients, and that's what we need to do. David. You're on mute, David. You're on mute, David. I don't know whether you can hear us.
Sorry.
That's okay.
Sorry, yes. Yeah. This is just a plea, really, because in Phil's report and in all the papers, there are so many good things which are happening and so many things in planning and so on. And as we move forward towards ICS and local government, merging and reorganisation, I'm just concerned to lose some of these really good ideas. Like, in Phil's in 2.7, he talks about health navigators and coaches and social prescribing and all that thing. How are we going to ensure that the really good ideas and the things that are happening, we're not going to lose as we necessarily move towards new structures? And how can we keep that focus on patients' needs, really? There's probably no single answer, but I think the more we move forward, the more I'm concerned that the voice of the patient is going to be lost in reorganisation.
Yeah, thanks, David. Phil, I don't know whether you wanted to come back on that point or any reflections on that.
Yeah, I will do. Thank you, Nigel. Yeah, good point, David. I'm looking out of my window, and when I look out of a window, it's usually because I'm thinking. So I was thinking about your question, your point, and whilst I was looking out the window, I was reflecting on the exec meetings that we have, and most of our time, and by most, I think nearly all, if not all, is spent on keeping the organisation safe from a statutory perspective, but also on doing our very best to shape the organisational change and the service change for the future, whilst supporting our staff. So the point that you've made about celebrating what we have done well, continuing the things that we are doing well and building on them, and involving the patient in that. There is a real risk that we lose some of that. So I think that's a very good and valid point. Thank you. That if we could note that, Nigel, we'll give that some thought. because I'm not sure we're in that space at the moment. Other exec colleagues are probably in that space more than me, but personally I have to say I'm not in that space. So yeah, I'll give that some thought, thank you, and maybe come back to that.
Great, thank you. Anything else for to comment on for Phil's report? No, that's great. Thanks very much, Phil. So just again flipping screens, and now we're going to go straight on to Michelle's quality and patient experience report. And there were a couple of attachments as well that were separate to the documents that went out. So over to you, Michelle.
Thanks, Nigel. So I'll just pick out a few things by exception, and as always, really happy to take questions. And just because it's in the body of the report and in order, then I'll take vaccination update now, if that's okay, and Steph will join in, I'm sure. So where we currently are is, you know, I just am in awe of my primary care colleagues for pulling this off. I really am. You know, we're talking about nearly 300,000 vaccinations across North Yorkshire and York already. And the contribution to that has been enormous, and they have just cracked on with it and want more vaccine every day. If I just could have more, I could do more. So I applaud you for that. I also want to thank Public Health for their support, because you know, I don't think people realise the amount of collaboration that's gone on between public health colleagues and the CCG in particular, especially around identifying cohorts and also keeping the responses back to the public flowing, because there's been an enormous amount of queries about when can I get my vaccine, why haven't I had my vaccine, and Steph and I deal with those in huge numbers every day, but so do Public Health on our behalf. Corporate messaging together on the same page in terms of being really pragmatic about cohorts. So I want to thank them for that, and really coming to the fore more recently around those seldom heard and inequalities work that we're starting, which I'll tell you a bit more about that in a minute. So where we currently are is we've done cohorts 1 to 4, and saying we've done, that means we're allowed now to move on to 5 to 6, but we are still pushing on the health and social care staff that haven't been vaccinated. There are still, from what we know about the data, and the data's not perfect around this cohort, is that we do believe, based on the data that we've got, that some health and social care staff, particularly in care homes, have not yet been vaccinated, mainly out of choice. And we're doing a piece of work to encourage that. And we would encourage the clinical leads of the care homes to take personal responsibility for their care homes too, and try and encourage that, because we've got some really good examples. Jocelyn Patel stands out in terms of what she's done with one particular care home up in the Vale area in terms of encouraging uptake to now that we've got 100% of staff. So, you know, I just want to, you know, thank Jocelyn for that, but there will be other examples as well of that personal responsibility being taken for that. So we are pushing on that. And so what we're busy with now is cohorts 5 and 6. Cohorts 5 are the age 65 and over, and they're being invited nationally to the vaccination centres, and primary care being asked to concentrate on cohort 6, which is a huge group of 16 to 64-year-olds with underlying health conditions, and a great long list of underlying health conditions that are prioritised, and unpaid carers, and they're in huge numbers too. And we rely on, you know, the coding patients to enable primary care to identify them. And the LD cohort, which has been expanded, as you'll have heard in the press and the media, isn't as straightforward as it might seem, because we rely on the LD registers of primary care for them to be able to identify them. But there are also instances where people might be coded with autism, but not coded with LD. And there has to be some jiggery-pokery behind the scenes to absolutely make sure we've captured everybody that's got a learning disability. And I know that, you know, Ruth can talk about what she's done in her patch to make sure that that's happened. Just a word of sort of warning is that may increase the denominator of people with LD that are now on registers, and that's a good thing. But of course, our LD health checks compliance may therefore look even worse going forward than they currently are. So just a little pinch of salt there in terms of how that might start to look. So so that's happening at the moment. And then cohort 7, which are the over 60s, are also started to be invited nationally as well. And we know that's based on national data about when the Department of Health decide to go next with the next cohort. It doesn't necessarily mean that we have done cohorts 5 and 6 and now we're going on to 7. And so we do get this inequality of people coming to Askham Bar, to the mass vaccination centre, who meet cohort 7, so are over 60. But we know that people with underlying health conditions haven't yet been done by primary care. So that is just the way it is. And the phrase that people are using is to try and get everybody over the line at the same time. So we've seen a reduction in our supply of vaccination in order that other parts of the country can catch up in the way that North Yorkshire and York have been successful. So that is an equality issue, and that's the right thing to do. But we see locally, some discrepancy about that, which we have to help people understand. So we are working in 2 ways around those seldom heard groups and those that are disadvantaged. Because as you say, they're not hard to reach. We just haven't reached them properly. And Steph and colleagues at Nimbus and elsewhere are doing quite a bit of work with the LD community and making sure that how they get their vaccination is in a way that helps them understand what's happening and isn't frightening to them. We've had a couple of instances where that's not been the best patient experience for them, going through, a sort of model which suits most people but doesn't necessarily suit everybody. And Nimbus are putting on a sort of special clinic for those with LD, where they've had advice and support from people like York Inspirational Kids and Public Health as well, around how we could make that environment more conducive to having a vaccination. But we also know that, the people who have the best relationship in primary care are those that see them in primary care on a regular basis. So it's not one size fits all at all. And we got plans in place started to have plans in place with the Gypsy Traveller community too in York. They have had quite a good uptake already, but trying to absolutely make sure that we can support them. With the homeless, as we've already mentioned, with our Eastern European colleagues as well, we have some information which suggests to us that they're not having the uptake that we would like them to. Sometimes difficult to know where you are with the data with specific groups because it's not always helpfully broken down for you, but we're determined to try and find them. And then Louise Wallace, the Director of Public Health in North Yorkshire, has started a sort of strategic assurance group with colleagues from City of York Public Health and with the 2 CCGs in North Yorkshire and York, under their statutory responsibility for health protection, to help us find those people too, not just for vaccination, but then, once we have found them and built relationships and ways to contact them and work with them, we could use that for other things going forward. So that's going to be really good as well. Second doses have started in earnest. People waiting for supplies, but people are starting to get their second dose. And of course, that's as well as people getting their first dose as well. And just to reiterate the messages about social distancing and hand washing, none of that can go away, mask wearing. We're not vaccinated till we're all vaccinated, and we are still seeing outbreaks in care homes, for example. It doesn't make you completely immune to this virus at all. And we still need to be absolutely as careful as we can be with our approach to that. So that's all I was going to say about vaccines. Was there anything else to add, Steph, that I haven't covered?
Thanks, Michelle. Perhaps just a couple of links to what we've already heard this morning. So we do have really good numbers on the big vaccine approach. So cohorts 1 to 4 were in the 95, 96, 97% vaccinated. But people have choice and choose not to take up a vaccine. So just reflecting Charlotte's comment about how we engage with people and how we listen to, we're all about, and who hasn't been done, how do we get 100%, how do we get 100%? We have to acknowledge that if we're confident that we've made the right approaches, people can choose not to take up the vaccine. And then just a couple of examples that perhaps reflect David's point. I've got a call booked for somebody who rang our contact us, and the query was straightforward. Me and my partner are over 60. When will we be called for our vaccine? And by the way, we're not registered with a GP. So of course, I will handle that on a one-to-one basis and facilitate a vaccine. But what that does is prompt me to think about, oh, okay, what more do we need to do to identify those people, to make sure that we've got our social media, our print media, so that people understand that we work locally and nationally to make sure, because actually everything that we do is geared through people who are registered with a practice. So we are listening to patients and we extrapolate individual stories to adapt our approach. And just by also way of reference about those other groups where we need to flex a big approach to something specific. We've just been in touch with the 2 mosques in York so that we understand our offer for those people who are going to be participating in Ramadan, which will commence on the 12th of April. Just thinking about that's likely to be the time when people will come forward for their second doses, and they may not take up their second dose in the hours that we run our services. So we're just working with practices to be flexible and allow those clients who are participating in Ramadan to know that they can ring, cancel and rebook without any sort of anxiety that they'll still be vaccinated. And we're doing that in collaboration with our local imams. So I just wanted to reflect that we do the big stuff and we talk and celebrate about the big numbers, but Michelle and I are also in the detail of how we work with those smaller groups in the 1s and 2s and 10s and 50s. So I hope that gives you some reassurance.
Yeah, great, thanks. Ruth, I think Ruth wanted to come in. Michelle, is that okay?
Yeah, of course.
Yeah, no, just really briefly. Firstly, yeah, thank you for everything that you're doing. It's fabulous, and I think the practices and the vaccine centres are doing brilliant work. And it's really reassuring to hear how we're kind of trying to approach people where the vaccine uptake isn't so good. I think that's great. I just wanted to come back on LD health checks, not health checks, LD vaccines, and just sort of reflect that I think it's a really, really good opportunity. I think it might knock out our numbers a little bit, but we've known for a long, long time that our GP learning disability registers are not capturing everybody. And I'm really hoping to embrace this opportunity to find people who might come forward who identify themselves having a learning disability, and we can absolutely improve our registers alongside work that we're already doing to do that. And we've done an awful lot of work in Selby and my practice about finding people, but we've still found a few new ones with this opportunity, which is great. The other thing is, I think there's a bit of a risk though, because there are people inaccurately on the register, and there may be a risk that we inaccurately put people on the register with learning disability, and the real grey area around autism and learning disability, and I think it's really challenging that, and it's very difficult, and it's very difficult for. I can't get my head around it completely, and I've done a lot of looking into it. So I think it would be really difficult for us to know which people with autism also have a learning disability, because the figures are around only about 40% of people do. But there may be a big drive for people to want to get a vaccine, and I don't know what to do about that, and I'd maybe welcome a bit of a conversation about how we manage that as a system, because I think there's a risk there, and then also I think there's a risk that you can upset people without wanting to, really. So I've kind of briefly emailed a few people about this, but maybe I need to pick it up with you, Steph, at some point about how we manage that and that grey area. And then just echoing what you said, Michelle, about making sure that we have reasonable adjustments in for people with learning disabilities about accessing the vaccine. So I think there will be a certain cohort of that those patients who will need home visits, and just making sure that we do those when necessary, really. And I think in Selby we're really working out, who can go to the big centre, who might need a more personalised approach, but still in a GP surgery, and who will need a visit. So yeah,
good to hear.
Right. I think Helena wanted to come in as well. Helena?
I think just listening to what Ruth said, I mean, I can echo everything that Ruth has said, because every practice, I think, has got a list of patients, particularly with autism, but there is a wider group as well, who are now asking, and who we are now wondering, who has learning disabilities or not. What is lacking for most of these people who are now adults, most of them, is we don't have access to the educational assessments. We don't have access to detailed understanding about whether or not they have learning disabilities, or whether they have learning difficulties that is not at an extent that's a learning disability. So there's a lack of information, and this puts us in a really difficult position. Sometimes it's really barn door, most of the time it's not, particularly for mild learning disabilities. Guidance, if I'm doing this in my practice and Ruth is doing this in her practice, and I've been watching Andrew nod away because this is obviously happening in other places too, we could really do with some guidance as to how to resolve this, because this is a particular issue. But if I take Pickering as an example, I've got 35 people to check by the end of the week, and on almost all of them have no educational report to tell me what's going on. So
okay,
could we work out something with the support of the learning disabilities consultants with the paediatricians? And there's something that really is important in language about LD going forward. Every single paediatrics letter from every community paediatrician, from every clinic letter, uses the word learning difficulties, not learning disabilities. In my experience of having checked 100 records in the last 2 months, the term learning difficulties is so wide, it doesn't then allow for us to be able to use learning disabilities confidently. And I suspect if Ruth and I aren't confident, then I suspect that the large majority of GPs in the Vale of York are also not confident as well. Or maybe we're just underconfident, Ruth. We need to reflect on that.
So what I would say is be really pragmatic. If you believe these people are vulnerable enough to need a vaccine, despite what they're coded as, you do that. This is a numbers game to some extent. Everybody will get vaccinated at some point in time. And the JCVI cohorts are based on the science about the risk of harm and mortality from that. And they have chosen the age groups rather than occupation to do that. And they stick by that. So that's one thing. And we would support you absolutely to do the right thing. In terms of that education assessments, we've already had a conversation with Karen McNicholas, who is our Children and Young People's lead in the CCG, who we've also now employed a DMO whose role it is the health aspects of education healthcare plans that people have, some people have. And obviously, she can have access to those who have an EHCP in the council. So we can do some work collaboratively with the council about those who have an EHCP up to the age of 25. Obviously, that would give you some information about whether or not they have a learning disability, if you want to really drill down that much. And if you feel you need that kind of information, there is that way in. But I sense that you might spend so much time trying to determine whether somebody fits the cohort when the next age group will come and they'll fit anyway. So, or they might have an underlying health condition. So I would just say, do the right thing and be pragmatic about it. That anything that we can help do, then, we're very welcome to do that. And Chris has put the tool in the chat box, but as I say, it is quite crude, but it might just help eke out. And if I can you know, it isn't easy. I get that. So personal experience here. My nephew has autism. My sister's boy, and he's 23, and he can't wait to get his vaccine. He's been, you know, had a high level of anxiety about the virus, and tells everybody off who's not sticking to the rules when he can see them doing that, either out of his window or in a shop. And his mum's had the vaccine because she's his carer, but he hasn't because he's down as having autism on the GP register. And 5-6 times a day he might ask when he's getting his vaccine, and he will happily go to Askham Bar, and he's desperate to go. So I had a conversation, his mum had a conversation with the GP, and the receptionist said, well, no, you're not coded as LD, you're down as autism. So my sister had to get Harry, my nephew's, permission to act on his behalf to try and sort that out. And in the end, he's emailed the GP practice himself to say, I have got a learning disability, I've got an EHCP, I'm still having education support, please let me have my vaccine. And so far he hasn't yet heard, but that's the kind of process that people are having to try and get through. So when you're trying to identify them at that end, there are people out in the community who believe they have a learning disability, who can't sort of get that way in either. So I don't know whether we need to do some comms and empowerment for people with autism in those other groups to say, if you believe you have a learning disability and you've not yet been called in, maybe we could do something around encouraging that. I suppose if we do that, though, they don't want to be met with a, well, no, I don't think you have got a learning disability. So it's not easy, but you know, I think it works both ways. Do you have your your hand up, Andrew? Not your Andrew up, Andrew.
It was just to say that I agree with everything that's been said, and this has actually come up in my practice this week, this issue. And I think that what you've said is exactly right, Michelle, in the sense that obviously we'd want to do the right thing. I guess that my worry would be that doing the right thing in this context would mean probably over-diagnosing learning disability, and that's all very well when there's a reason like getting the vaccine, but then that code obviously then stays on a patient's record forever, really. And I don't know that people understand necessarily the consequences of having a code like that if it's not appropriate. So I do think it's slightly more challenging than just saying it, you know, err on the side of give the vaccine.
Yeah, I suppose I meant don't necessarily code them as LD. If you still believe they're vulnerable, then give them the vaccine. Don't necessarily code them as LD.
Yeah.
We're just waving at that. Yeah.
Yeah, I just wanted to, I think that the approach needs to be exactly that, Michelle. I think look at each case, look at the vulnerabilities, but be a little bit cautious about adding codes, and then maybe put that aside and do the harder work about trying to figure out whether this is the learning disability or not, then or just learning difficulty at a later stage. But maybe just, you know, as you say, be pragmatic, be kind, look at the vulnerability, and go from there. Really, I think and I don't know how you put that out, you know, without sort of looking like you're bending the rules as such, but I think that's the right approach. And if we could all take that approach and then sort of delve into the detail, maybe at a later date, I think that's the right way to do it. Otherwise, I think we're going to end up causing unnecessary angst at both ends for patients and for practices, and so that's the approach I think is the right approach to take.
Yeah, I would agree with you. And I think that, you know, if you flip it as well, there is an opportunity to identify those with LD that aren't yet coded and therefore not necessarily getting the support that they need to. So yeah, it's a good approach and one I would support. Anything else, Steph, on vaccines? Okay, so just moving on to some other bits in the report. So CHUV had an unexpected and unannounced CQC visit, and the report is not yet in the public domain, so we weren't able to say too much, but just as it says in the report, they visited premises that were in the North Yorkshire patch, so not in our Vale of York patch, but of course we have still the same provider. and they were concerned about their risk assessment and risk management processes on the whole, and as such have issued a Section 29A letter, which means that they do have to act urgently to make a difference to that and make improvements. And they have done that straight away, and we're part of the group, the improvement group. Denise goes to that, and I think they are making good progress. So more on that when it comes, but we thought you should be cited on it. In terms of maternity, just to let you know that the Ockenden report that we talked to you about before is out and has a number of recommendations. And one of those is around the maternity medicine centres. So those with underlying health conditions that are also pregnant, and they are a must do, and they're happening quite quickly. So we're looking on the ICS level about where we might have a maternity medicine centre, and the CCG has contributed financially to that as well. And the local maternity services, the LMS safety network, which is described there, I think it's just worth pointing out that they are now taking on responsibility for serious incident sort of management and incident management, when the CCGs have statutory responsibility for that too. So I think this is the kind of first time that an approach on an ICS level is being tested out. And as CCGs get sort of less and less involved in some of the functions that they currently do towards the end of April 22, it's important that as a CCG we're still cited on anything that might be happening in terms of maternity safety through that group. We have got representation on that group from the CCG, but I think it's just an interesting move and one we need to keep an eye on, and one that we're discussing at QSG next week in terms of how will that work, and are there any blind spots across the ICS if that happens in that way. Hopefully it'll be a really positive thing, but I think it's just an interesting move, and one that we'll see more and more of. Just to let you know, in terms of serious incidents, QPEC agreed to archive the 12-hour trolley wait risk that was previously sat at governing body, and subsequently, which has been a sort of helpful lever, I guess, to do that, is that we used to have to declare an SI for every 12-hour trolley wait, and that is now not required nationally. Obviously, it will still be an SI if it meets definition, but they don't routinely. And I think that's the right thing to do. I think it was a way of counting 12-hour trolley waits, but the vast majority of them were de-logged as SIs because harm hadn't occurred, and the providers could demonstrate that they'd kept people fed and watered and safe while they were in the department for a long time. Okay, so on to patient experience, just to let you know that really the vast majority of our queries are around vaccine, and with the help, again, of public health and of patient experience team, and Jill in particular, manage those queries very regularly on our behalf, and I want to applaud her for that. But you can see some of the themes that are in the report there, and not unexpectedly. Just want to pick out a couple of things from the engagement section. We don't often talk about this, but the Parkinson's disease nurse, that was, what is described in the report is the engagement that happened as part of the review of that post. And that fed through with even more evaluation of that post to exec committee week before last, where we wholeheartedly supported the continuation of that post. In principle, we're just trying to find the money, but how much difference one person can make to a population with Parkinson's is amazing. And we know there's some inequity there in the city, but there is a different model, and they do have further access to the hospital in a way that more rural areas don't. So Gillian's made an enormous difference to the lives of people with Parkinson's disease. And then also the Northern Quarter, I don't know whether Denise wants to say anything, but just to let you know around the Northern Quarter work, which is around how we develop services based on the engagement activities of those with mental health. Some great work going on there, and you can see it's described in the report and how it will help with services and pathways. And you'll see a new comms and engagement dashboard, which we applaud. So I think it's great that we can see our comms and engagement colleagues working, and it gives you a snapshot of the work that they're doing. And certainly within the CCG, we're finding that really, really helpful way of describing that. I think it's really helpful. And then down to the risks. So you'll see a description of the risks that sit with QPEC and what's happening with those. That's there for you to read. And we've got a good handle on those, and we talk about them frequently and thoroughly, and do deep dives if we need to. But the two that currently now sit with governing body as agreed are hepatitis B service. So the risk is the same. It's not increased and it's not decreased, and we don't take our eye off it yet because we're at this tricky point where the service is supposed to be taken over by YFT from April, and we have some jitteriness about that, I think, because we know that they're not quite ready yet, and we know that our GP colleagues will support them, and we are just worried about the transition of patients into that service and people falling through the gap. So I don't know whether Steph wants to say anything more about that, but it's their responsibility. And if you remember, the history of that was it's a specialised commissioning service that was then gifted to secondary care to do instead of primary care. And CCGs, in one sense, have been in the middle of that, trying to make sure that patients get their vaccination and trying to do the right thing by liaising with the LMC and primary care and secondary care to try and get it sorted for something really that wasn't particularly broken in our area and worked quite well. So it's left us with some difficulties. Did you want to come in with anything, Steph?
So I think that York FT are engaged in the work that they need to do. We've just had a delay in progress, given that different bits of the system have been focused on COVID. So we have held that risk to make sure that there is continued effort and focus on this, and we're just going out to ask York FT to do an equality impact assessment, again as another mechanism for making sure that they are assessing the risk of the transition over the year end. So yeah, we're very much focused on making sure that it doesn't fall off the.
Thanks, Steph. And then the other risk, and hopefully it will answer Bill McPate's question, is around the 0 to 19 service review from North Yorkshire County Council and the planned changes there. So you'll have seen our joint response that was in the appendices, which has gone into their overall consultation. And there was a stakeholder event on the 17th, 19th of February, which we were involved in, where they were discussing some of the consultation comments, and they have already started to re-look at their model and make some changes on the back of the consultation, but also on the back of the fact that the changes were stalled during COVID, and COVID itself has led them to re-examine, particularly around safeguarding, when you don't have the contact that you previously would have had with people and families. So that in itself has made them rethink some of that. What their actual plans are, we won't know until the end of March, when the plan is that it would go to their county council exec. So we do still remain concerned that there will be gaps that probably health will need to pick up, and especially around sort of emergency contraception and continence, but we're hoping not. And we remain concerned about the safeguarding elements of that and being sure that we are in contact in the early years with people. So we are remaining very close to it. And the other plan is that we have a new exec between North Yorkshire, CCG and ourselves, and we have raised it there as an agenda item, and we are asking the council to come and talk us through their plans in the next few weeks as well. So then we'll know a little bit more as well. So I think that's what I have to say really about the report.
Thanks very much. Helena, did you want to come in about, I think you put your hand up with sort of around the Parkinson's service. So do you want to come in on that?
Yeah, I mean, so I was involved a little bit, or I am involved a little bit in the Parkinson's stuff. What I wanted to really highlight was the lessons learned about evaluating a new service. So I came in late to the project for various reasons, but I came in at the evaluation stage. What we learned from Macmillan when we implemented care coordination was that Macmillan used masses of qualitative evidence, so patient feedback and clinician feedback on when they implement the new service, because when you implement a new service, what you don't know is how much unmet need is there. So if you KPIs are all about, you know, preventing things going downstream and various other things, but actually you open up a project and you find that there's masses of unmet need, clearly you're not going to reduce referral. You might increase referral. You're not going to reduce admission necessarily. You might increase admission, but the key is that the care is actually improved. So what we did with the Parkinson's project was apply that learning that Macmillan had given us through care coordination and do the same thing, which created a power around the project and the evaluation that was not there from numbers alone and was not provable from sort of just population, from health data. And the other thing I wanted to add was the importance of using population health data to understand why this was really important and valuable, because the service was created to I suppose, ameliorate a gap, mitigate for a gap, and the gap being particularly about distance and remoteness with the combination of frailty in Parkinson's and cognitive impairment, which is so prevalent in Parkinson's. So this combination of factors about distance and remoteness from a service when your need is very significant, and bringing that population data into the arguments, I suppose, in that evaluation was, I think, really, really important. So I suppose for me, what I'd like to see is that when we come up with business cases and when we come up with new things that we're trying to innovate, that actually those things are absolutely at the heart of the initial project plan and therefore the evaluation at the end going forward.
Yeah, I completely agree with you. And we could see that really strongly through the full evaluation that we saw at Exec. It was, you couldn't argue with the case at all. It was just brilliant.
Thank you.
Great. We will document our thanks to that team for that report that's come through and the work that's done. Thank you very much. So the governing body is requested to determine whether we're assured of the quality being undertaken to understand and support the quality and safety of the Commission services. And I take it that we are with this report, unless anybody wants to raise anything at this point. No, that's great. Okay, so that's great. Thanks very much, Michelle, for that update. And actually, you're on next for a verbal update about COVID-19. You've done a big bit about the vaccination. Is there anything else that you wanted to bring to us?
Now we've got Sharon with us, so she might be able to help us with the sort of infection rate, which is improving. What we can definitely see is the effect, well, nationally on hospital admissions and the severity of illness linking with the numbers of people that we have vaccinated, particularly in the elderly population. So, you know, it's getting us to be where we need to be in terms of reducing and easing lockdown. From a testing point of view, testing is going well. As you know, schools open next week and lateral flow testing is required, well, it's voluntary, twice a week. And I know from personal experience that started in my house too. So quite an undertaking, I would imagine, for every secondary school to be doing this, but they do have support of volunteers and public health and others from a testing point of view. And PCR testing continues and not to be an issue, when in the beginning of COVID we had to find some local solutions to that. Hospital is feeling less pressured for sure. They're starting to flip their COVID wards back to non-COVID wards and reducing their ICU beds. So, you know, the green shoots are absolutely there for improvement. And fingers crossed it continues that way. I've mentioned about outbreaks in care homes. They are reduced, but we're not out the woods in terms of you can still get an outbreak in a care home despite vaccination. So I don't think I wanted to add anything else around COVID, and maybe Sharon would come in and she's not here.
Sharon?
Yeah, shall I come in and give a bit of an overview? Yes, our overall infection rates are coming down. York, City of York has had a bit of a blip in that our numbers increased, but are now coming down again. So at the moment, North Yorkshire's infection rate today is 62.6 per 100,000. So North Yorkshire at the bottom of the Yorkshire and Humber league table. So they're in the best position with the lowest rate of infection. And then York is just above North Yorkshire. Our rate is 66 per 100,000 today. Just to put that in context then, the regional rate is 128. So North Yorkshire and York are doing pretty well in terms of overall infection rates. And that data is for specimens or samples taken up to the 26th of Feb. Our local data, local intelligence, yet to be validated by PHE, shows that the infection rate is actually lower than that. So we can have confidence that our infection rates are falling. The age groups that are really driving the infections across North Yorkshire and York are in the 20s, 30s and 40s age groups. So they are not groups that are in the vaccination cohort. So what we're seeing is vaccination is definitely helping, as Michelle has already indicated, with the older age groups in terms of hospital admissions, and we can start to see those falling. But because case rates are being driven by the younger age groups, we're really trying to continue to get that important message around infection prevention and control measures and people's behaviours around social distancing, limiting the number of people that they have contact with, wearing face coverings in public places, getting lots of fresh air, ventilating their homes well, and hand washing are still really very important. And I think as we move into more of a recovery phase, as we start to implement the government's roadmap, kind of really doing everything we can as a system to continue to push those messages and help even those people that have been vaccinated to understand that those measures are still really important. Promote the importance of regular testing. We have really good access now across the system for symptom-free testing through lateral flow tests. We have good access to testing for people with symptoms. That continues to be really very important. And then obviously people engaging with local contact tracing is important as well. And those are tricky messages to get across because, you know, if you look at the national media, it's all about, you know, you could imagine that the pandemic is almost over if you read the national media, whereas, you know, we need to balance those hope messages with the fact that we're still living with a pandemic and all of those measures continue to be really, really, really important. But a lot of positive messages. Hospital admissions down, as we've said. Deaths from COVID are also falling. So lots to celebrate there, but we need to continue to push those important behavioural messages as well.
One other thing I think probably is worth mentioning, and I know I'm preaching to the converted, but it's about workforce going forward to manage. So although there is a positive improving picture and one we have some confidence in, the vaccine programme will still continue and need a significant amount of workforce to continue that, whilst also standing up business as usual services. And primary care are, you know, they will really need to plan for how can I get back to business as usual and use other or different workforce to continue that. I mean, there's already talk about boosters every year for the vaccine, etc. It's not going to go away, and then before we know it, we'll be back into flu vaccine season. So, you know, we are talking to primary care about their plans of being able to do that. So I think it's just worth noting that, you know, I don't think it's a risk, but it's a real difficulty.
Ruth, did you want to come in on that?
Yeah, we've had a few discussions about that in Selby this week, actually, and I think it's worth noting that it is harder in the outlying areas who are sort of delivering, you know, the sort of vaccine centres there, because you know there's, I think, probably a bit more of an impact on your practice staff, practice managers, and things in those areas versus, you know, what you can deliver in a really big mass back site in York, really. So it is a challenge for us, really. We know that it's, you know, our practice managers and staff have been working just so hard to deliver the to deliver the vaccine in Selby, and it's probably similar in Tadcaster rural Selby area and up in Shire, as it is everywhere. But we're really grappling with how do we continue that versus you know, really kind of getting back to normal with the core service, and we're looking at all the sensible things about, you know, upskilling volunteers and finding other people, but it's things like project, you know, an operations lead and things like that our practice managers are doing at the moment. That's the sort of challenge that we're getting, is somebody who can fill that gap easily, and where do we find those sorts of people? So it is a bit of it's potentially a bit more of an additional pressure to your outlying PCNs, really. Yeah.
That might further inequality, right, and inequity of access for vulnerable groups, especially in deprived areas such as Selby. That's me saying that as a Selby GP, sort of that I would worry if the Selby service wasn't there.
Yeah, I think it's really important that it's there in Selby, because you will get a better uptake, and patients are saying, no, I'd rather, you know, I'll come to Selby, and it's sitting in an area, in the most deprived area. The vaccine centre is sitting in that deprived area. Those people wouldn't be able to get to York, so it's really important that we maintain it, but recognise the pressure that's putting on the practices to deliver their core role as well. So it's a real challenge, but we're trying to work through all the possibilities. And I think Richard, our PCN manager, was going to try and speak to CCG about, you know, that operations leady type person, whether there's any help we could get there somehow to release the practice managers to do their really important role back in the practices. So thank you.
I'd be happy to have that conversation, yeah, by all means. And I suppose the other thing that's worth mentioning is the services that are being put forward for long COVID, and you know, nobody's done this before nationally, and there are different models that are being put forward, and really as tests of change, because we don't know, you know, what these individuals might need. You can guess some of it, but some are having, you know, very different models being put forward, from nurse-led to, you know, full-on respiratory consultant. So those models will emerge, and you'll be able to know how you refer people into those services. Pulse oximetry at home continues, which is useful for silent hypoxia that may creep upon people when they're poorly at home with COVID. Yeah, so I think those are the main things that are happening with COVID.
Great. Helena, is that an old hand or a new hand? Old hand. Okay. I suppose the other thing to flag, Michelle, is the national, regional, local efforts around restoration, and where that's going to go over the next 3, 6, 12 months, and how that is a very difficult situation. It is a difficult situation and will be a difficult situation, but it is something that everybody is looking at, because the waiting lists have got longer and longer for people, haven't they? So it's how we manage that, how we look at people to help citizens wait well if they are waiting for certain interventions, and how also we can maybe help for other ways of people's needs, getting to people's needs.
Absolutely, and there's also you know, unwavering support for staff wellbeing, but a concern around how you give people a rest, especially frontline services that are just coming out of the most horrendous situations they've probably ever found themselves in, and describing sort of what's called vicarious trauma by what they're seeing every day, and the number of deaths and harm that's occurred, especially in acute hospitals. while still expected to flip back to normal and continue to try and get the waiting list down. It is a concern of people's health and well-being.
Yeah, thank you very much for flagging that. Okay, thanks for that. So we're going to move on, and the next bit is over to Abby for the board assurance framework to receive this.
Yep, so again, I'm not going to go through it in detail. You've seen the format of it before. We've updated all of the risks on it. You'll be pleased to see that there are fewer red risks on there now. There is also now an additional strategic objective and an additional slide to take account of the work around health inequalities and population health. So we've added that on there. One thing is, because we're trying to make sure that this is sent out with papers rather than sent out the night before, there are new risks potentially emerging between this being sent around with the papers and you having the meeting today. So if that happens, we'll try and update you about any new risks that have come on, particularly where they score highly enough that they would fall into governing body, but there aren't any between the papers being sent out on this meeting. So unless there's any specific questions, just to receive the board assurance framework as it is, please.
Yeah, anybody got any comments on any thoughts or anything about the presentation of it? David.
Thanks. Yeah, no, I think it's really good, and thanks to everybody who's worked on this. I think it's very clear and readable, and I particularly like the sort of summary at the end on page 72, I think, which is very clear, and we can monitor it. So I think it's been quite a lot of work for Abby and the team. So I think it's been a good piece of work.
Yeah, great. Phil, did you want to come in, Phil Goatley?
Yeah. Thanks, Nigel. Just echo what David said. It's been a large piece of work, been a lot of work over quite some time now to refine over a number of iterations the BAF, and I think we've got it to a stage now where it captures as many of the risks at every level in the organisation as it's reasonable to. We looked at it in detail again at Audit Committee last week, and we not only signed off the BAF as is, but also the underpinning management arrangements which feed it. So all very positive there. Thank you.
Great, thanks very much. Thanks for that, Abby. That's great. Okay, so that's that bit. And of course, we have talked about that we have received the finance report, and Phil alluded to that earlier on. So we're probably just a few minutes early for Michelle for the next step. I don't know whether Christine has joined us yet. Just have a look. Not yet. So what I can suggest to people is, Ruth, did you want to put your hand up?
Yeah, it was just within the finance report, there was a bit about the underspend on additional roles, and it was quite significant. Is that a reflection? I don't know if there's anyone here that can answer. Is that a reflection of this last financial year of PCNs not being able or having the space to kind of completely use their additional roles funding and get people into those roles? Is that why we've got such a large underspend as such in that area? And then I suppose moving forward, it's to make sure that maybe we don't let that happen again. I know it probably helps the finances, but it doesn't help the service provision, maybe.
Yeah, I wonder whether Steph, are you able to talk about additional roles?
Yeah, it's a mixed picture, Ruth. Some PCNs have really been able to move forward and recruit to those posts, and we created some freedoms within the guidance to also use agency. And actually, I think what's in the current report perhaps doesn't reflect where we might be with the end of year position. So there's definitely, I hesitate to call it an underspend because it's a reimbursement based on what you've been able to recruit to. So it's it is there for people to use and draw down. So I think the position is slightly improved to that which has been reported. But yes, where there are areas of non-recruitment to the plan that PCN's put in place and reflect, it is because of either the time available for the PCNs to actually do the recruitment or unsuccessful recruitment. So I think there's something about lessons learned or group recruitment, and just how we think about, and maybe through Gary and Fiona's roles, how we make sure that we're supporting that and supporting it at the right time in the year to get the maximum benefit of the reimbursement that's available to you.
Andrew?
Yeah, sorry. On that note, can I just quickly ask a question that came up in one of the LMC roadshows, well, last night's one actually, about slightly on this topic to do with the mental health practitioners that are included in next year's contract, because there are some PCNs, and one PCN in particular, that have taken the initiative of starting recruitment for this early, and it was suggested in the roadshow that probably because they've done that before April, the funding won't be covered because it won't be seen as an additional role. And the feeling was that would be kind of really against the ethos of a PCN DES contract, and particularly if there is an underspend, that, you know, if we do call it an underspend, that would seem to be a fairly controversial decision for PCN. So are you able to comment on that at all, or is that something you'd be able to get back to us about?
I can certainly get back to you. We're still waiting for the national guidance, and for colleagues who perhaps aren't aware of this, under the additional roles, PCNs over a 4-5 year period are being released access to funding, and the type of role is being phased in. If you remember, it's really to try and smooth out recruitment in line with training. And so, you know, you will be very familiar with the conversations that we're having about what is coming with in relation to mental health issues, particularly at a primary care basis. So very late, we got some initial guidance that our mental health providers, that the scheme was going to change slightly, or rather greatly. There is an advantage to it. So the theme is that our mental health providers will be part of the recruitment, and that there'll be a 50-50 recruitment and funding. Basically, a high level advantage that you'd have a specialist mental health unit that could offer cover, training, supervision. But as Andrew's highlighted, we knew that this was coming, and we're keen to see a model in practice. Across the Vale, it's in the order of 19 whole-time equivalents. So not unsurprisingly, there's a bit of a flattening, but I would agree that if the CCG has a level of flexibility about this, as we've previously shown, we would look to support the process, but we await further guidance, and it's being raised and pushed through. And I think with every good idea, when it gets socialized, the unintended consequences of it start to be shared. So yes, we'll come back as soon as we can, and we'll use Gary and Fiona to just make sure that message is populated through both our CD meetings and our meetings with the LMC.
Thank you, Steph. The other thing is the obviously the employment, you know, who holds the employment contracts for the mental health workers, but I understand that's also not finalised yet. So thanks for that.
Great. Thanks, Andrew. Thanks, Ruth, and thanks, Steph, for clarifying those, and also for the work you're doing with that. I'm going to do. So it's great. Okay, so now moving on into the last bit of the agenda, items 11 and then into 12, is assurance around the Safeguarding Adults annual report, and then also we've got the MAPA arrangements annual report as well. Michelle, do you want to introduce this?
Yeah, so Christine's with us. I think she might be on leave, bless her, but she's appeared because she's obviously much closer to this report. It's for 1920, which, you know, there's a time lag. It's been to QPEC for scrutiny as well. And when it came to QPEC with the MAPA report, it's the first time we'd seen the MAPA report, and we thought it was well worth showcasing it at governing body so that you could see all those multi-agencies that support adult safeguarding. So Christine's going to briefly take us through it. Thanks, Christine, you've appeared. Are you on leave?
I am on leave, yes, yes, I'm having a lovely holiday. I'll do the MAPA report first, if that's okay. I don't know, I've done some slides, but I won't put them up. I'll just chat through it really, because I know you'll be tight for time. But as Michelle says, I shared the MAPA report. I think it's a really important report, and it's a key piece of work really. And I shared it with Quality Committee really just to illustrate the positive work that's been undertaken, and really that expanding safeguarding agenda and how we've engaged and embedded MAPA processes into primary care over the last few years. So the report does take you through a kind of introduction for MAPA really. If you're not familiar with it, it's a framework for sharing information for risk assessment and really the proportionate deployment of resources to target and support offenders who were assessed as presenting a serious risk of harm to the public. The MAPA responsible authorities are the police, probation and prison services, so they are the key actors in this, but we also have a duty to cooperate. So there is a list of services who fall under that duty, and that's social services, ourselves in health services, youth offending teams, the job centre, local housing understandably play a key role, and education. And there are also in MAPA meetings a host of other kind of third sector agencies who also play a crucial role. So just to take you through a little bit of the offender management, there are different categories of offenders, and they're kind of listed there, categories 1 to 3 in the report, and then different levels of management within those categories. So for ourselves in the safeguarding team, and the risks that we share with primary care are really the meetings that we attend are from level 2 upwards, where a formal MAPA meeting is required to manage the risks that those offenders pose. And that's where we get involved really. And we are kind of called the single point of contact for health services. I will just say at the side of that, our colleagues in mental health services do sit on all MAPA meetings, so they kind of extend that duty to be in every, but we cover primary care in the safeguarding team and all the other secondary care services. The crucial role, I think, is illustrated really well. They're described as critical friends, and I think that's a good way of describing the 2 lay members whose role is kind of to represent the voice of the community and ask those critical questions and contribute to the strategy. And they do describe well their 3 layers of engagement that they have in the process. I won't go into too much detail about that, but I think that's critical really, that they are in that process to kind of ask questions that you know the public would ask about these processes importantly. The COVID challenge is illustrated as we're all keenly aware of, that not leastly for offender management. There have been some exceptional challenges to maintaining the service. and that's well described within the report. And I think it's, we can't underestimate the dedication of the offender management teams to maintain the effective service during the challenges. And I think the illustration there is, we can rest assured that in North Yorkshire we have a robust, exceptional delivery model to work to. And there's been some significant challenges, I think, from our perspective. What was always evident within MAPA meetings was a teleconference facilities if we weren't able to attend in person. Initially, everyone was using those teleconference facilities, and understandably they didn't work terribly well. So those meetings have been much improved with the use of Microsoft Teams. And that's been a kind of helpful addition, really. From a health and wellbeing perspective, we share an agreed level of information with primary care related to the risk and the health of the person involved, and also other people that might be involved with that individual closely. And we also share that information with secondary care partners if they are close to the offender and the offender might be having active secondary care treatment, or they might, obviously, as anybody can, attend any emergency department. So it's just managing that risk in the environment that the person might be in. We bring our expertise from safeguarding and health, and we cover all GP practices across North Yorkshire and York with this information sharing. We also go wider than kind of the North Yorkshire boundaries, and cover some GP primary care practices just outside our area, where potentially we've got approved premises that people regularly are placed in. The report then covers criminal and civil orders, which are used regularly as licence conditions and managing offenders. And they are numerous. Usually applications are made by the police, but they can be made by local authority partners and others. And then some interesting information about polygraphing, which is a new tool that was introduced in October 2020. And it's been particularly useful in a number of cases. I think the case studies do illustrate the complexity and critical nature of the work, and crucially how that risk has been managed. And then at the end of the report, the data has been presented. I'm happy to answer questions if I can on any part of the report. I might not be able to answer, but I think in terms of data, it would be interesting to know whether you feel that those numbers, I guess, are what you might expect or came as a shock or surprise to you. So any questions on that report or comments?
Thanks, Christine. I'll see if there's anybody. David.
Yeah. Thanks, Nigel. Yeah. Thanks, Christine. I mean, it's a very comprehensive report, and it's an annual report is meant, I think, to be a kind of a positive document, isn't it, and report on the work of an organisation. But I wonder, what are the challenges for the future? It doesn't list any challenges, and I do know that some MAPA decisions do go wrong, and because that's the nature of the business. So to me, I just wonder, and I know it's not your report, so I'm not kind of putting you on the spot, but I wonder why there aren't any challenges in there, and what the MAPA organisation hasn't been able to achieve, which we know no organisation can. So it's really, there doesn't seem to be any lessons learned from anything that will possibly have gone wrong. I know an annual report is meant to be a positive document, but for me, it would have a bit more realism if everything wasn't absolutely perfect.
I think that's a really good point, David. Thank you, and I'll feed that back to the team. about that. I think when I was looking at this, I think one of the challenges has been one of the challenges for the future is currently that court processes have stopped during the COVID pandemic or have slowed significantly, and so we have more people who have remained in prison. And I think, like we're expecting with all our services, potentially there will be then a flurry of people going through court processes and being released because they've served their sentence whilst being on remand. So I think there could be a kind of significant increase in numbers that we see, and requests for attendance at MAPA meetings, and requests for, and obviously for an increase in the work of probation. And I guess it's that safely managing the opening up of services, and being able to start to safely meet people again, face to face in the way that they would have done, because some would have had very close contact with probation, and that amounts to a kind of phone contact at the moment for many of them, which everybody will appreciate. That doesn't give the same assurance as a face-to-face meeting can. But I'll feed that back. I think that's a really helpful and a really good comment from
thanks,
you.
David.
Thank
Chris?
Yeah, I guess it's just a bit of feedback. Maybe not your responsibility, Christine, but the presentation of the MAPA reports back to primary care are quite difficult to decipher, really. I'm sure they're really easy for the people in those meetings and in that process. And the information that is in there is really useful, but they often run to 9, 10, 11 pages, and we'll have a list of people and outcomes which are difficult to decipher. And we have safeguarding meetings most months. We might run through 10, 15, 20 people in those meetings, and it's really helpful for the information presented back from those meetings to be succinct and relevant. There's often a lot of repetition from previous meetings in them, I find, and trying to find the relevant information to make it of value. You're not alone in this. We have the same discussions with mental health trusts and out their letters, the hospital, everyone else. It's a rock and a hard place, isn't it? But I'll be willing to work with whoever comes up with the MAPA reports to make something primary care relevant and useful.
I wonder if you're thinking of a MARAC report and minutes from a MARAC meeting. The MAPA information sharing is generally just one side of paper, which just lists different.
Okay, that sounds good. Yeah, maybe
it just lists the different risks, as we don't share the minutes of the meeting with primary care. You would be getting a huge amount of information that wouldn't be relevant to. But I think it's possibly that you're getting the minutes of MARAC meetings, which I think will run to several pages of information. And I agree, it will be difficult to pick out the bit that is then. But that then is an argument of kind of, thinking up for the future as a process that might actually be more helpful for primary care in picking out the key details.
Yeah.
For MARAC and mental health.
And mental health, yeah. Never cracked that nut yet.
Great, thanks, Chris, and thanks, Christine. Okay, any other comments on this bit? Yeah, Julie.
Yeah, mine's just about the efficacy of the polygraph. There was a time when this means of measuring was actually slated, and have we got better at it? Is it a more efficient process?
I can only say, Julie, that I hope it is, because when I kind of learnt of this, I think It is a process that I think has warranted some criticism in the past. It isn't used widely, but I think in the field there is enough evidence to support the use of it in the limited way. It's another tool in the box, so it is just will be used on cases, and it's never going to be the kind of thing that is it provides that complete level of confidence and complete assurance. It will be one measure against many others that will be used to kind of make decisions about people.
Thank you, Christine. I like having tools in my box.
Me too.
I just had to say it because I was aware of that kind of chatter that goes on publicly, and I thought it was good to highlight it.
Yeah. No, I was similarly interested to see the use of it, actually.
Great.
It's fascinating. Thank you.
Thanks, Julie, and thanks. Okay, Christine, so I think, do you want to move on to your next report, which is the Safeguarding Adults report for 2019-2020?
Yes, thank you. So we do illustrate the team members. Obviously, there's myself as designated nurse and my colleague, Olwyn Fisher, and then we have two Safeguarding Adult officers within the team, Jackie and Jane, and a full-time team administrator who we keep exceptionally busy. And then the wider team is Jeanette Griffiths, who is our named nurse for primary care, and Nikki Heels, who joined us in May of this year, I should say. So not strictly speaking, part of the 2019-20 report, but I think Nikki feels like she's always been with us, really. So I do want to, Nigel's nodding, she's been such an incredible difference, and it feels like she's always been there. So she's a fab addition to the team. And then Nigel is the named doctor named GP for Safeguarding Adults, as he is for children. And then you've got the other three North Yorkshire GPs, Dr. Shacklock, Dr. Billingsley and Dr. Owens, for the different areas. The report really just takes you through the strategic priorities and achievements against those. So I'll just pick out some of the key points of that. It is a fairly short report this year. So we had an audit in 2018-19, and that really tested our performance against our statutory obligations, and we've completed that action plan now. So that's priority one, was completing that action plan. And that was kind of the bits left on that were the revision of the Safeguarding Adults policy, which has been completed. And we've further this year developed a joint managing allegations against staff policy. We've had those procedures in place before the policy, but we've brought them together from a children and adults point of view, and implementing the training strategy, which has been a key piece of work. Priority two is our assurance with our provider organisations. So we have established attendance within internal governance meetings for our key providers, and also really good relationships with our safeguarding teams. And we provide a lot of peer support and advice to those teams on a virtually daily basis, really. And we have a strong health partnership group which meets on a quarterly basis, which does provide that kind of ongoing peer support and a real significant route for sharing information and developing safeguarding practice across the area. Three is partnership working, and our obviously key partnerships are with our safeguarding boards, but also, significant partnership is with the community safety and prevent and channel processes. And I think it's important to remember that below every board, there will be a number of operational meetings and task and finish groups and subgroups, etc. So that's, a huge amount of work that takes place in those groups. Priority 4 is our work with NHS England. NHS England a couple of years ago did a sort of face-to-face assurance test, an assessment of that for each CCG within their area, within the north of England. One of the things that we were lacking in at that point was the training strategy, primarily because there wasn't a nationally recognised training strategy from an NHS England perspective. That was then published in 2018, and we developed our training strategy in 2019. And as I said, that's being implemented now. Priority 5 is safeguarding adult practice. We have 2 safeguarding officers. They've been involved in over 100 inquiries. Sometimes that is as part of a bigger inquiry. We provide the health information. From a York perspective, it is undertaken in what we call entrusted inquiries. So the local authority entrusts that process to the CCG, and we go from sort of start to finish with it, and then send it back to the local authority. So whilst our inquiry numbers have decreased since last year, because they were 169 last year, you will see that that's not the same for York, where numbers have been the same in 2019-20, around about the same. And obviously that excludes the number of advice calls, etc., that we take, and the inquiries that we get that won't meet the criteria for a Section 42 full investigation, but there's still a significant amount of work to kind of get to that point where we feel that the risk is sort of enough that concern can be closed. Never underestimated our links with primary care, and we've now got a well-established programme of hot topics training. They're always well attended. They're usually well received. Safeguarding is a difficult topic for lots of people, and so there is challenges in delivering that training, also receiving that training. Information with primary care, I think, has significantly improved in general, but particularly, as said, in relation to MAPA and as we briefly talked about in relation to MARAC. And MARAC is the multi-agency risk conferences for high-risk domestic abuse cases. And then finally, the Learning Disability Mortality Review Programme. The steering group is established now, and we've got links through with the Transforming Care Partnership. We've had recruitment of a specialist nurse for the programme, and Alison works 2 days a week. And then crucially for York, we've had recruitment of a service improvement nurse to lead on the Learning into Action programme and supporting individuals and services. I think looking ahead, it's been a challenging year, as it has been for across the board, really. So I think we've got concerns and challenges related to COVID-19. We've had issues around our care home sector, with obviously reduced oversight into care facilities. Virtual contact has replaced that face-to-face assessment and inspection, and we've responded to concerns from relatives and also whistleblowing from staff within those environments. And I'd say that it's, we've got established strong multi-agency partnerships, but never more have they been tested, really, than in the last 12 months. I think another significant challenge for the CCG and the safeguarding team will be the implementation of the liberty protection safeguards. Their implementation was delayed, due for last October, delayed because of COVID, and now due to be implemented in April 2022. Although 12 months away, it is a significant amount of work that needs to be in terms of process and practice change to implement those. And of course, the local impact of changes in health and social care systems and processes and boundaries and arrangements that we all have to kind of get our head around, and particularly for us in safeguarding, see where our role fits and where we need to be placed. I think I'd just like to say thank you to the CCG, and thank you particularly to Nigel and Michelle as executive leads for safeguarding, because we couldn't do our role if we didn't have those well-established relationships with the quality team and with other areas. I don't think there's an area in the CCG that we don't reach through to, and I think that's really positive. So I'm happy to take any questions.
Great, thanks very much, Christine. I was going to echo the thanks back. Really, you know, our safeguarding relationships through primary care out through all community care has improved dramatically over the last 5 years, and so I can say that as a practicing GP that we have seen that through the work of the team. So thank you. Julie, did you want to come in?
Yes, please. I was going to say thank you, Christine, for being here when you're on holiday. You're amazing. I really appreciate that. Can I ask you, you mentioned whistleblowing. I wondered if we've got any themes coming through and what we're going to, you know, knowing you're probably a step ahead, what are we going to put into place to try and mitigate the things that we're hearing?
I think the key bit is listening to people, which we always do. I think it's and the challenges have been obviously around short staffing, people, you know, bit cited as not following the right precautions, etc. They are always looked into, so it might not be a CCG. Sarah and her team do go in, as public health do, and do that kind of follow-up work in terms of infection prevention control. I think some of it for me will come out at staff support. So how I think we've got much better established processes within, and even they, as we know, will be challenged from an NHS and a local authority point of view in terms of staff support. I don't think our sort of private provider care workforce are supported in the same ways at all. And I think for some that there's been a significant impact, and I think we have to apply a compassionate approach to people who are raising valid concerns. But it is always about, supporting the environment to improve and maintain where possible. We don't want providers to fail, so we do try to put in as much support as possible to help them to improve back to safe practice. I think a big challenge will come when visitors are allowed back in to see their relatives. I think whether or not, and I'll use it broadly in terms of whether or not we feel people have been neglected, there will be a perception that just in the kind of deterioration, the normal deterioration of an elderly person who is very frail and who you haven't seen for a year, you're going to, you've only seen in a small square of a phone or an iPad. Some family members are going to get a big shock that their relatives have deteriorated in that way, not least people with dementia who, may not now recognise family members. So I think we'll have a huge wave really of that as well across the summer as more people and the challenge around kind of managing those and supporting our care providers to manage those relationships. So that there will be a kind of, I think, there's a fine line, isn't there, between being able to assure against quality and against safeguarding, and what is the kind of normal expected potentially deterioration of somebody's in the natural course of their disease process, or just aging process.
Yeah.
I'm not sure if that answers your question, Julie.
Brilliantly so, and I mean we've seen a trend as you bring your work through to committee, which tells us about communication and the way that links to each other has really enhanced and tightened. You know, the work of Michelle, yourselves, and Sarah, and the way it's the can-do attitude, and you are going to get the hiccups because people with dementia do deteriorate rapidly, and also because they haven't had probably the outside socialising that they would have done, and maybe less exercise than they would have done. So there will be a lot of diminished stuff. We're aware of that, and I think maybe we need to be thinking about somehow forearming people, and I don't know how we're going to do that, just so that they don't go in and have that full face shock of a deterioration, and I don't quite know what we could do, and I wish that we had a magic solution to, but yeah, there's been some really good work going on. So yes, thank you, and thank you for being here today.
Yeah, thank you very much, Christine. That's very kind of you to come in and do it on your annual leave. Okay, so that's the end of the agenda items, and I note just looking at the received items from the committee minutes and the comments on those. So thank you very much to the chairs of those committees for doing that. Finally, the next meeting will be on the 1st of April, so look forward to that in a month's time. And just wanted to lastly say to everybody to say thank you for sticking to the rules, for your compassion to other people, and what Julie's just mentioned about compassion, and how going forward there are a lot of compassion around what's happened, what's going to happen, and how we're going to have to deal with the legacy of COVID as we go forward. But as Sharon talked about, we're not there yet. The media is saying that we're there, but we're not there yet. We need to stick together, we need to stay safe, and we need to stick by the rules. And if we do that, then we will get through it, and we will get through it all together. So just want to say thank you again, everybody, for being here today virtually. If you are watching online, thank you for doing that.